All right, everybody, it is 11:25. Welcome back to the Arthritis Foundation's Live Yes Showcase. Again, I'm Melanie, and I am your moderator today. At this time, I want to thank our sponsors, Horizon Therapeutics and the Columbus Medical Research Foundation, for their support of today's programming. There are some housekeeping tips in the chat. We are recording the session today, saving question and answer until the end if we have time. And also take a look at the links for the insight assessments. We'd love to gather more information that we learned about in the plenary session this morning. And we will be ending this session promptly so we can move on to the next one on time as well. I'm going to take this time to introduce Dr. Stacy Ardoin, who will be introducing our speaker for today.
Great, thank you, Melanie, and good morning, everybody. I'm Stacy Ardoin. I work as a rheumatologist at Nationwide Children's Hospital, and I'm delighted to introduce our next speaker, Dr. Ed Oberle, who is proud to say my colleague. He's an assistant professor of rheumatology at Nationwide Children's Hospital in Columbus, and nationally, he's also a leader of developing ultrasound as a tool to diagnose and manage children with arthritis, and he'll be discussing his work concerning musculoskeletal ultrasound with us here. Thanks, Ed.
Thank you very much for the introduction, Stacy. It still says it's disabled for me to share my screen, so if the host can make that adjustment for me real quick, I'll be able to get my slides up for you. All right. Okay. So thank you, Stacy, for the introduction, and then the group this morning for inviting me to give this talk. I have been doing ultrasound in the rheumatology clinic for almost the last 8 years, since most of the time of my career as a rheumatologist. I started as a fellow. And I am going to be talking about specifically ultrasound that's done in the clinic with the patient there at the bedside, rather than just referring scans to be done by a radiologist, and talk about the advantages of why we do that, and when it comes to the diagnosis and treatment of JIA. And so this is going to be a fairly basic talk. I realize that there's probably not anyone with extensive radiology background following along, so the pictures are just for, you know, to kind of support what we're talking about. I'm not expecting anyone to interpret all the scans that I'm going to be showing, except I did have one family once where the mom was a radiologist and the dad was an anesthesiologist, and that was a very interesting clinic visit with lots of questions. I learned a lot. So I also just want to make a quick disclosure that I am not promoting any specific type of ultrasound machine or a company. So I have no financial relationship with any ultrasound companies, but as Stacy said, I do a lot of teaching, and I have had some honorariums for that before in the past. So the learning objectives for this morning, just to give you some basic overview of what is ultrasound, why do we use it, why particularly a rheumatologist finds that it's helpful to do ultrasound in clinic with their patients, and then what are the aspects with ultrasound that we use, particularly for juvenile arthritis, when diagnosing and treating it. And as you can see, ultrasound is an easy thing that you can learn just with enough practice. And with these very lovely little models here, I have become desensitized to ultrasound over time. I've done ultrasound on them, so many, they're my kids, that I hear them sometimes when they're playing Barbies that they're performing ultrasounds on each other. So it's maybe too much information background. So let's just start. What is ultrasound? If any of you, like me as a parent during pandemic, you've probably had too much Disney Plus and have seen Forky around, and he always likes to ask very important questions. So we'll start off with, what is ultrasound? So ultrasound, in order to get it, you need to have a couple of items. One is that there has to be a transducer. So this device here is what is going to make the sound as well as listen to it and be able to create the image. And then you need to have a screen to be able to create that sound and visualize it. So within the transducer, there's an array of crystals, and those crystals are very small, and when you turn it on, they start to vibrate. And as they vibrate, they produce sound waves, and the sound waves will go towards whatever you're aiming it towards. And then, so in this scenario with JIA, it's often a joint, and then it bounces back, and the transducer hears the sound and creates that echo into a picture. Now, the other thing that we're missing that you can see the screen isn't showing anything as far as a joint is that you need something for the sound waves to travel through. And that's where the ultrasound jelly is really important. So the jelly, as annoying as it is important to be able to get those sound waves right to where we need to, so that we can then visualize that image nice and clear. And so we can see in the screen here, there's a nice moving knee. And so things that are really solid like bone are going to be bright white. And then things that are softer like tendons and the other tissue is going to be various shades of gray. So with ultrasound, what can we see? So this is an example of a shoulder and a wrist, and we can see the bone, we can see tendons, we can see nerves. There's the ability to find blood vessels, and then it's important for blood circulation to be able to tell when someone's got active disease, because the blood vessels within the tissue become swollen and then become brighter on the screen. You can see the lining of the joint, the synovium, which is probably the most important thing for a rheumatologist, and then muscle, ligaments, and then cartilage, which is essential when seeing young kids that are developing. So one of the reasons that we're using ultrasound more and more, even though it's an older technology, is it's advanced so much over the ages that we're able to get really good details. So this is the first example of an ultrasound used for musculoskeletal purposes back in '72. And this is the back of a leg, and there's a cyst right here. And now the technology is so advanced that we can see that so clearly. We can make really good, accurate measurements and see the fine details of the tissue that we're looking at. So that's why this is being adopted now after being around for so long. And then why an ultrasound compared to other types of imaging? So this is a sideways view of the knee. It'll be a little more evident here in a second when I click. But with the ultrasound, we're able to see, the soft tissue really well, which is where the synovium, the joint tissue is. Compared to an X-ray, you can get a really nice overview of what the bone looks like on X-ray, but it's very hard to tell if there's fluid there, if there's swelling in the joint, what the tendons look like. And then compare this to an MRI, and an MRI gives us excellent details of the joint, the bones, the tendon, the tissues, the swelling, but it takes a long time to get an MRI done, and often you require sedation, because you have to be perfectly still for 30, 40 minutes at a time. But it gives you a really nice overview, but it can't be done quickly and it can't be done repetitively. The one downside with ultrasound that I'll say compared to an MRI is the window that you can see is much smaller. So that box that just got outlined is the only field of view that you can see on an MRI, on ultrasound, compared to an MRI. So it is a little more limited, and you can't see within the bone. So there are some drawbacks to ultrasound, but in general, it's kid approved. They tolerate it. It's done very quickly at the bedside. There's no radiation, there's no IVs, there's no sedation, being put to sleep. Really, the only drawback is the gel, which if it's cold can be a little uncomfortable. So if you have a nice machine that warms up your gel for you, that's really not an issue. It's repeatable, and the most important thing for as a rheumatologist is that we get the answer right then and there, and we know what to do, rather than having to wait a week or so longer to be able to get someone in for radiology to get the information that we need. So it's really quite valuable at the bedside. The other thing is it's fun, kids enjoy it. There's always, when I'm scanning, people are making comments about the things on the screen. And so it's engaging. This is a finger, but there's often, debate on what animal or creature it looks like. Some people will say, oh, it's a manatee. Other people have said a gorilla. This is a sloth. I personally think that it's Jabba the Hutt, but there's lots of interpretation. You never know what the kids are going to yell out and say what they see. And so it's really quite entertaining and enjoyment. So other reasons that rheumatologists are using ultrasound is it's challenging in some patients to tell what's going on deep inside their joints. If someone has a little bit of extra skin folds, a little bit of weight on their joints, it can be difficult to tell if there's fluid or if there's swelling deep inside. And especially really young kids, toddlers particularly, where they've got this extra body fat, it's hard in those little chubby toddler hands to tell, is there swelling in a joint? And so the ultrasound can help us see through that. The other reason clinically is that kids complain about pain for many reasons. And particularly in children that have had arthritis from a young age, as they get older, they've had some behavioral changes that they know that if they say that, you know, something hurts, or if they just want to be carried, that they're going to get a little bit of extra attention, or they can be carried and picked up. They don't have to walk around the zoo so much. And so it's hard to tell from symptoms, you know, is this something behavioral, or is there really still something going on? And then same with our teenagers, you know, when we're seeing a lot more depression causes joint pain. And so it can be reassuring to get a scan to see that there's no active disease, and knowing how to best treat other comorbidities or things that are affecting patients. The other reason is that joints are complicated. I mean, this is a foot and ankle, and there are so many ligaments, tendons, joint spaces, little pieces to be thinking about. Where is the disease? How is it affecting somebody? And so, you know, just for ourselves from an anatomic standpoint, knowing where the disease is, ultrasound can help us. It's also important for me to be able to show families what's going on inside their child or the patient. And so, for an example, this is a picture of the knee, and this is a sideways view that is showing us the long part of the femur bone and the kneecap. And in between those two is where we see the disease. And so that red space is where all the inflammation is. And so this patient in particularly had arthritis, so you could tell that they had it on exam, but the family didn't feel like the symptoms were really bothering their child enough that warranted putting them on treatment. And so when I got the ultrasound out and showed them what was going on, and then really pointed this out, that right here, this is where the growth and development is taking place. It's surrounded by inflammation, and that inflammation is going to affect the way that that bone grows. And so visually being able to see what's happening inside has allowed some families to feel more comfortable with starting treatment or making changes in their treatment, with being able to understand what's going on more internally. So in summary, why rheumatologists are using ultrasound is it's great for diagnostics as well as for disease monitoring. It helps us improve our skills and our ability to be able to teach families, and to you know, use our interventions, which I've got some pictures about here towards the end. So there are disadvantages, however, to ultrasound. It's not a perfect tool. The main thing is that it takes a long time to learn how to use it proficiently. And not only does it take a while, but it's dependent on who's doing it. It's dependent on the patient, you know, how cooperative they are. If you're very squirmy and you're moving around, you're not going to get accurate pictures at all. All machines, there's variability from machine to machine, from brand to brand, to type. And as I alluded to in the pictures with the MRIs, we can't see everything. The other thing is there are joints that we know that ultrasound doesn't work really well for, such as the TMJ, which is the next topic, and the back, the vertebrae, the sacroiliac joint. Ultrasound really isn't good for those areas. We also don't have great understanding of what ultrasound normal is like in healthy developing children. And these pictures that I'm showing here highlight that this is all a picture of the back of the heel, and they're all healthy, normal heels, but depending on how old the patient is, it looks completely different. So they're really young patient at the top of the screen to a fully mature grown teenager ankle at the bottom, is it looks drastically different from age group to age group, and even within ages, depending on how mature one person is developmentally. And then having arthritis changes the way that bones grow. And so sometimes you get more advancement in the way that the bone looks in someone that's had arthritis. So there's a lot of variability. And because of this variability, it's difficult when working through groups like CARA to apply ultrasound to research studies, which is why we have a work group in CARA looking at ultrasound and ways of being able to standardize all of this. And so one of the forefront interests of our research is how can we compare an ultrasound that's done here in Columbus to a patient that's being seen in Boston when they're on the same trial, the same medication, and there's some variability in their machine. So that's the one, I think, would say major drawback with ultrasound when it comes to research. But clinically, I think it's a very powerful tool to use in the room, in the bedside. So how can ultrasound be used specifically in the diagnosis and treatment of JIA? And so this is a recent picture. You can see we're still doing ultrasound in the age of COVID. And so when we are doing ultrasound with JIA, the main things that we're looking for is the confirmation of inflammation. So for the diagnosis, what's going on in the joint and the tendon, we're able to identify joints that clinically are silent, where you may not know that they're having symptoms, but there could be some inflammation there. It's helpful for monitoring disease to know when someone is in true remission, and then for procedures. And so the specific things from a arthritis standpoint that we're looking at is we can see fluid within inside the joint or fluid around the tendon in someone that has tenosynovitis. You can see that the joint lining is swollen, and that I talked about the blood flow going through that when it's really inflamed, and you can see that the disease is active. The joint looks like it's on fire sometimes. We can see changes of the tendon sheath, and more specifically, right when it's inserting onto the bone in patients that have enthesitis. And then with long term, you can actually start to see some damage that's applied to the bone and the tissue, specifically erosions. And so there's a various amount of things that we can look at when we're trying to assess the type of inflammation and what process is going on in the joints. One thing that I have become much more appreciative of with ultrasound is its ability to find things that I wasn't expecting. And so like having an aha moment. And so specifically, I'm going to share the story of this case with you. So this was a patient that I saw, a teenager that was coming in with arthritis in her knee. She was high school, getting ready to apply for scholarships for track and cross country for college, and had been having knee pain for a while. And examining her, I could tell that she had a really swollen, warm knee consistent with inflammation. It was only her knee that was bothering her. She had no pain anywhere else. And as I was explaining, the diagnosis of arthritis to her, she got a little upset, that concern that this was going to impact her ability to run in high school and college, and was saying, no, I don't have arthritis. And so I used the ultrasound again, just to kind of give her a little bit more insight. And then she was looking at the screen, and very appropriately, she said to me is, I have no idea what I'm looking at. Like, I've never looked at an ultrasound before. What does this all mean? So the one nice thing about most people is they've got two sides to their body. And so if you need a comparison from one side to another, you can put the ultrasound on the other knee to be able to see what normal looks like. So I said, this is what your swollen knee looks like. You can see this area here, the redness is where the fusion is. So we looked at her knee that didn't have any pain or swelling, and shocked, she had an even bigger amount of fluid in that other knee. And I didn't know how to explain that to her, other than the fact that we're learning more and more that ultrasound is able to pick up silent or subclinical arthritis in some joints. And so this is the busiest slide that I have. This is a study that was done where they scanned over 1,600 joints in about 50 patients or so. And each of the joints is represented on the bottom. And the main thing looking at is the center, the white bar, and then the bar right next to it, where with the wrist, for example, there were quite a number of patients where the exam was normal, but the ultrasound was abnormal, and vice versa, where the exam, the clinical exam, showed that there was concern for abnormalities when the ultrasound was normal. And so there are lots of times when scanning people that I do find something that, I am questioning if something's there, and see something that helps me indicate that there's probably a little bit more inflammation going on in this patient than we truly appreciated. And that's even come to fruition yet, to the point where the patient is experiencing a lot of symptoms. One thing we don't have a good understanding with as a researcher and a clinician is should we be scanning every patient and looking at every single joint all the time? And so one of our current projects in CARA is working on a way to reduce the number of scans needed to do for an overview, a survey, and really get down to just a couple of joints that are very sensitive to being able to pick things up. So I'm not endorsing that everyone needs an ultrasound of all the joints all the time, but this is a field that we're learning a little bit more about. And there is always that kind of, like I said, aha moment where just something is found that I wasn't quite expecting it. The other aspect of that is what to do with it in the long run. There are some evidence that says that those joints with time will start to have symptoms. And so should we treat them early before someone starts to get any pain or stiffness in that joint? And some studies say, you know, that's not necessarily going to change with time. So we're still learning for that as well. The other aspect that ultrasound is really helpful with is just pinpointing where the inflammation is. So in this study, they looked at 49 swollen ankles where the rheumatologist thought that the swelling was in the joint of the ankle and nowhere else. And what was found was that there was a lot of swelling in the tendons in some patients where they only had swelling in the tendons and there was no fluid in the joint. And then a lot of patients where it's a combination of things. And so this is important for when you're considering to do a steroid joint injection, making sure the medicine gets where the disease is. Or I often think if I'm having someone that has a lot of fluid in their joints and they're having multiple tendons involved as well, I'm probably going to step up their therapy and use something a little bit stronger right from the beginning rather than wait and give it a little bit of time. Ultrasound is a good way to monitor the disease activity. And so in this example, this was a patient that had enthesitis, so inflammation in the tendon of their Achilles tendon as it inserted onto their heel. And so at the time of diagnosis, you can see a lot of red in this picture. That's the inflammation taking place in the tendon. After a couple of weeks of treatment, that inflammation was appreciated to be going down on ultrasound. After a few months, we could see that most of that was gone. The patient at this point had no symptoms, but we still saw some inflammation, so decided to continue the anti-inflammatory. And then this should say after 6 months, so I apologize, the number still says after 3 months, everything was gone. And at that time, we decided to stop treatment, and the patient did fine afterwards with no recurrence. And so ultrasound is a good way of being able to kind of assess, are we in remission? Are we in not only clinical, but ultrasound remission? Now, the one thing that I will say is that ultrasound is a point in time. And so it's really easy when I see fluid and the tendon of the joint is swollen and that there's lots of inflammation of that redness. But if those things aren't all there and we're just seeing that there's a little change to the lining of the joint, I don't know for sure if that's just residual left over from someone that's had arthritis before and it's better and this is just kind of scar tissue, or if someone's about to develop arthritis flare. And you know, it's helpful to have longitudinal or repeated scans in some people, but it can be difficult at just a single assessment when you're getting just that one-time look at somebody, knowing where this is going. And then, like I said, you can see some long-term things, erosions and tendon changes as well. Seeing arthritis, seeing someone who's in clinical remission and finding that they still have some findings of ultrasound abnormalities is an area where there is debate still about, does that mean if we stop therapy, they're going to flare? If you're an adult with rheumatoid arthritis and your joint is still showing some inflammation and your exam is normal and you're not having symptoms, it's been shown that that's a good predictor that if you stop medicine too early, the disease is going to flare. It's still out for debate in pediatrics. And part of this is because there's a lot of variability of what a developing joint looks like. And we see lots of healthy blood vessels inside of joints. And so a lot of the studies that have been done previously have erred on the side of saying any sign of blood vessel or circulation in a joint means that there's some abnormality, when I think we're appreciating that that's not the case. So I anticipate that as the research continues to go on, we're going to see it is a little bit better of a predictor of who's at risk for flare as we start to apply specific definitions to these ultrasound findings. And then the last thing is that ultrasound is really helpful for doing injections. In the one study, it was shown that just using ultrasound improves accuracy of where the injection is going. And so something as big as a knee, which often can be done without ultrasound guidance, there was still about a quarter of patients in this one study that were done blind, finding that the medication ended up not within the joint space itself, within the surrounding tissue instead, versus a much smaller percent, only 4% on ultrasound guidance. And then using ultrasound, you're able to avoid nerves and tendons, and you can make sure you don't go far too deep and bump into bones. All of that is very painful. And so ultrasound reduces the amount of pain that patients can experience with an ultrasound, with a joint injection. And so on this lower study, you can see there still is some pain with an injection, but the amount on the 0 to 10 scale was lower at 3.7 compared to 5 without ultrasound. And then when I do ultrasound, like I said, it helps me ensure that I'm in the right place. So you can see the needle moving around in the fluid there. When trying to suck out fluid, sometimes it doesn't come out, and you can see that the needle is in too far, and we can readjust it. And then I think it's very satisfying seeing the medicine move around and circulate into the area where it needs. And sometimes people have very odd kind of anatomy within their joint. There's a lot of folds, there's a lot of thickness, and there's compartments. And so the ultrasound can help us make sure that the needle's getting into the right place. Small joints like the fingers are really hard to get into blind. And so with ultrasound, you can make sure that the needle is right where it needs to. And again, you can be reassured that you're seeing the medicine circulating around. You can avoid all those sensitive structures, the tendons, the nerves, to kind of get into the tendon sheaths. And then the last example here I have is a Baker cyst, the swelling in the back of the knee. You can be sure when you've gotten all of the fluid when doing an aspiration, you can see everything shrink down and all that swelling go away. So in conclusion, I hope that you realize why, as a rheumatologist, I and many others like to have ultrasound in the room. It helps us be able to see the joints and the tendons better. You can see the different ways that inflammation from juvenile arthritis is affecting the joint. We can monitor the response to our treatments, and then it makes injections more efficient and less painful for our patients. So thank you for listening. If there's any time left, I'm happy to answer a couple of questions. And this is our team nationwide at the last Jingle Bell run in person. So thanks.
This was great. I do think we have, 2 minutes, I think, Jasmine. She will put the next session link for the TMJ and JIA in the chat. But if anybody has any questions they want to send over, you can do that now. Let's see.